Good afternoon, everybody. This is Don Capoferri coming to you this afternoon. I want to thank ChiroSecure for the opportunity to bring you part 2 of documenting patient care. So let's go to the slides. We're going to do a quick review of part 1. And I'm going to blow through these pretty quick. I believe you have the opportunity to go back and look at the video for part 1. If you see some information on part 2 that maybe you missed on part 1, or maybe you weren't attending part 1, and you can go back and run that replay if there's information that you missed, and go ahead and get that. Just real quick on this home page, the title, Documenting Patient Care. I also want you to notice that I am a clinical instructor at a medical school, State University of Buffalo School of Medicine in New York, and also adjunct faculty of Cleveland University in Kansas City. So what I'm teaching you is what gets taught in those institutions. So it's not something that we're just making up. This is also brought to you by ChiroSecure and Simverta. Simverta, in my opinion, is the #1 patient care documentation tool for a chiropractor. That may be even a new concept for you, but every specialty has to document patient care. If you're a primary care physician and you're working with a patient for hypertension, obviously the blood pressure readings are how you document the effectiveness of your care and whether the person needs continuing care. If you're working with diabetics, of course, the blood tests, the glucose tests. If you're a rheumatologist, the biomarkers for inflammation are how you judge the effectiveness of what you're doing and the need or not of ongoing care. So for chiropractic, in the past, we've used range of motion, we've used different things, but I reviewed in part 1 that contrary to what the scuttlebutt is, and actually contrary to even our national organization's stated policy, there is absolutely no evidence that anyone is harmed by diagnostic x-rays, particularly in a chiropractic office. And we went through that you'd have to take thousands of x-rays, about 5,000 cervical x-rays, to come close to the harmful threshold for radiation exposure. Now, I'm in practice 41 years, still in active practice. Part of the reason we started a few minutes late today is traffic on my way home from seeing patients this morning. So I'm not a consultant. I'm not disengaged from what happens on a day-to-day basis in a chiropractic office. So we reviewed, let me click on that again, see if we're moving. Okay. All right, we are not moving.
Your slides are changing on my end, Don. I don't know if you're seeing you're on a slide net. Do you see that?
All right, so
it says safe use of X-ray right now. Then it's automated demonstrative. I don't know where
okay.
you're going with this.
Yeah, they're starting to move now. Well, actually,
okay, cool.
They're moving without me controlling it.
Well, that's frightening.
Yeah. So what slide do you see now? Automated
demonstrative validation of comorbidity.
Okay. So what you're looking at is a report from Simverta that you're able to produce a disc height analysis report. One of the reasons I put this slide in there is because disc degeneration is a comorbidity that prolongs the expected patient response to treatment. So how do you do that? Well, you can actually take upright standing lateral cervical x-ray, measure central disc height, and then measure the height of the vertebral body below. And anything, if the ratio is 33% or higher, that's a healthy disc. 33% or lower is a pathologic disc. Or you could just digitize the patient's x-rays and get this report, which shows at C6, C7, a disc with loss of disc height, which is a primary indicator of disc degeneration pathology. So that becomes now a comorbidity, and there are others. But this is objective documentation of degenerative disc disease, which can prolong your care. Traditionally, we've used range of motion studies or motion palpation, and what you're looking at now is the poor inter-rater reliability of motion palpation. And then X-ray analysis, particularly from Simverta, that next page shows very high scores of inter-rater reliability using X-ray digitization. So this is something that's accepted in the community and is duplicatable from provider to provider, from patient visit, or transitioning patient care from one frequency to another. And as you document that, there's less carrier resistance in paying you for your care because you have the documented need for it. Now, how traditionally we would manage the success or failure of our care, most chiropractors would not admit this, but they do it based on pain. So we have kind of a pseudo pain management profession, chiropractors, and a pain management profession, which obviously uses medication and injection therapy to manage patients' pain. Where what I'm excited about is taking the subjectivity out of that and entering the objectivity into it by using digital X-ray biomechanical analysis. As definitive diagnosis, it's reproducible from one provider to another. It's demonstrable to the patient, it's demonstrable to the carrier, or in the medical legal community, it's demonstrable. We do it all the time. That's just so you know, that's pretty much where I live in the medical legal world. It's legally defensible. It also prevents you from being accused of predetermined treatment plans, because your treatment plan is not predetermined. It's determined based on your testing and eval and X-ray biomechanical analysis. Okay, so I believe this is where I stopped last time. One of the relatively misunderstood tissues that get into issues in our spine are the ligaments. So you're looking at actually the Golden Gate Bridge there. Ligaments are suspension cables of the spine, just like the bridge has suspension cables. Now those suspension cables allow for a certain amount of movement of the bridge, particularly in weather, but they secure the bridge from too much movement. That's exactly what ligaments do in the body. The microstructure of ligaments, they're made of three things: elastin, collagen, and fibroblasts. Up until the time someone hits puberty, the fibroblasts, produce both collagen and elastin, and each joint has a unique percentage of collagen and elastin depending upon the amount of movement. Like your shoulder would have a lot more elastin than your spine. I don't know what the percentages are exactly, but collagen is more or less concrete. Elastin, just like it says, is stretchy. But once the person hits the age of puberty where the skeleton is matured, usually that's 14, 15, 16, something like that, fibroblasts never produce elastin again. So when a ligament is compromised, that compromise in the beginning allows for hypermobility of the individual segments that it was securing and is permanent. As I'm going to show you in just a minute, we're talking about sprains. That's the compromise of a ligament. And there's three grades of sprain. Grade 1, which is basically an overstretch past the paraphysiological limit. Grade 2 with a partial tear, and grade 3 with a full thickness tear. And at 41 years of practice, I've never seen a grade 3 walk into my office, most likely because they couldn't. If it was in the neck, they wouldn't be able to hold their head up. If it was in their back, they most likely would be able to walk. So they'd go right from the scene of the injury to the hospital and have orthopedic stabilization surgery. So ligaments are pre-tensioned. They allow some movements. Compromise allows too much motion initially. Eventually, ankylosis leads to too little motion. But all of our range of motion studies are focused on restricted motion, when actually hypermobility is far more egregious to the spine long-term than restricted mobility. What you see on the screen now is a report of intersegmental translation. Now, translation is one vertebrae sliding on the other. There's a certain amount of that that's allowable, and that's measured by the green vertical line you see there. Anything to the left to that green line or to the left of that line is normal. But you also see here at C5 that movement of C5 goes way past the green line, which is the pathologic threshold, and past the red line, which is an administrative line for full whole person impairment according to the AMA. And the software, which if you're interested, you can go to Simverta.com and look around, walk around, see what it looks like to you. But you can select 5th edition of the AMA guides if you're in a 5th edition state, and you can select 6th edition, because those two guides, 5th and 6th edition, treat this condition, which is called AOMSI, alteration of motor segment integrity, differently. So you want to definitely know which state you're in if you're going to do an impairment rating, and which edition of the AMA guides they use. Now, some states don't mandate. My state, Georgia, is a 5th edition state. So, and there are 6th edition states. There are Oregon, I believe, still back in the 3rd edition. So that might be something you want to find out. You can go to amaguides.com, click on the button that says Guides by State. Another thing, from a clinical standpoint, not just a personal injury standpoint, this hypermobility of C5 is a contraindication to manipulation, if that's what you call what you do, or chiropractic adjustment. There's no such thing as an adjustment that can make a vertebrae move less, only more. So it behooves you to know if there's hypermobility in your patient's spine and take appropriate action. In my case, this would call for a different treatment approach than an adjustment. And also same in the lumbar spine. Now, if you were to look at these x-rays, on the left, you have a lumbar flexion. On the right, you have a lumbar extension. If you look carefully, L4 is displaced anterior to L5 pretty significantly. That would be a grade 1 spondylolisthesis of L4. If you look to the pars, just posterior, you can see the lysis back there. And there's definitely some pathology there that would be diagnosed as a spondylolisthesis. And then if you look at the extension x-ray on the right, there's some retraction that we see of L4, and that movement is depicted on the report from Simverta in translation at L4-5 as movement. But we have more significant movement at L5-S1, past the pathology threshold and past the impairment threshold. So actually, the biomechanical pathology is worse at L5 than it is at L4, which is why we say you cannot eyeball this. I have seen radiology reports on MRI that say no indication of ligamentous instability. Well, first of all, that's absurd for a radiologist to comment on that, mainly because ligamentous instability would have to be evaluated by moving like we do here, flexing and extending. Evaluating ligamentous instability while someone's laying in an MRI machine is ludicrous, yet I see it all the time. I probably read 1,000 radiology reports a week. So it cannot be eyeballed, it has to be tested. So we just talked about translation. Now, translation is one segment sliding upon another, which is a compromise of the facet joint. The facet joint capsule is what restrains the gliding action of the superior surface and the inferior surface of the facet. If that capsule is breached, it will allow too much motion. And in an injury, sports injury, car crash, or whatever, what tears that capsule is when the facet joint retracts, not the extension of it, but when it retracts, it often tears that capsule. The facet joints are wired directly to the dorsal horn of the spinal cord and up to the brain, and that biomechanical malfunction, along with the ensuing pain, ping-pongs around the brain, setting off pain signals. So a facet, although not paid much attention to, kind of the redheaded stepchild of the spine, is often the site of painful, especially referred pain. What you see on your screen now, I believe, is the pain patterns for cervical facet problems. Yeah, big delay in moving of the slides. So, yeah, okay. So from suboccipital, mid-cervical, lower cervical, and then scapular pain, often generated by the facet joints. And you could take actually, if you want to take a screenshot of that, in fact, you could Google facet pain patterns too. Now, this is a pain pattern in the absence of clinical indications of radiculopathy or myelopathy. This is from the facet joint. So it's a little bit of a diagnosis of exclusion, but when you have Simverta, you correlate the Simverta report of biomechanical compromise of the facet with the patient's reported pain pattern, and that's a lock and key fit. Same true in the lumbar spine. You have the pain patterns there correlated to the translation pathology in the lumbar spine, in this case L5, facet compromise. Also, there's a compromise of the ligamentum flavum also, which allows for too much motion of the L5 segment, and then you have the patient-reported pain patterns. A lot of docs jump to the conclusion of if someone has lower back pain and leg pain that it's radiculopathy, but more commonly, it's the facet joint. Okay, now this is what I talked about before. This is the actions, the biomechanical actions of a ligament. There are four. Creep, which is a long stretch of the ligament. Tension relaxation, which is stretch and relax. That is what you see a lot of athletes do prior to competition. Then you have strain rate. Slow or fast, but no time to stretch. Athletes stretch before they compete. Chances are people in a car crash did not stretch that morning to prepare their ligaments for the impact that they are unaware is going to happen later in the day. And then you have hysteresis. So the most common cause of ligament damage is rapid acceleration, deceleration. We also know that as whiplash. The ligaments are not prepared, and there's a sudden movement, and the tissue pulls apart. Only when you have a grade 2 sprain, which is a partial avulsion, do you get hypermobility at the end. There is a chronic cause of facet syndrome, and that is a side effect of disc height loss or disc degeneration. In the normal spine, the vertebral body, disc, nucleus, vertebral body combination, or motor unit, we call that, is supposed to accept 70% of the biomechanical strain of the spine in any given day. And 30% is on the facet. But those ratios change as the disc degenerates. Strain and biomechanical forces now shift more to the facet. So you can get facet arthropathy, ARTHROPATHY. I was once doing a talk, and in attendance was a neuroradiologist. And I kept using the word that arthritis comes about as a result mechanical degeneration of the joint. I don't know where that slide came from.
Don, you actually froze for a second, so
Okay.
we lost about 10 seconds of what you were just saying. I apologize.
Okay, so I'll repeat that. There's a difference between arthritis and arthropathy. Arthritis, don't bandy about that word too much, because arthritis needs to be confirmed. So ligament sprain, a common cause of it are falls or sports injuries, motor vehicle crashes. A ligament partially tears and it results in hypermobility of the segments. There are 3 grades of sprain. I mentioned them before. Grade 1 is an overstretching. Grade 2 is partial tear. Grade 3 is full thickness tear. And you may have seen that on a radiology report, oftentimes in the shoulder or knee, full thickness tear of blah, blah, blah ligament. In the spine, grade 2 and grade 3 will definitely result at the acute phase in hypermobility, but chances are you won't see a grade 3 come into your office. 41 years, I've not seen one. Hauser and Doland wrote the kind of landmark paper in 2013 that ligaments, once compromised, replace the damaged tissue with inherently inferior tissue, especially after puberty. So ligament damage is permanent. That's another reason to manage your patients ongoing, because there is no bring the ligament back to pre-injury status or pre-compromised status. You might want to take a screenshot of this. This study by Leahy in 2012 talks about partial tears of ligaments having the equivalent compromise of the biomechanics as full thickness tears. So they just don't have the acute symptoms of a full thickness tear. Davis's law is what we're talking about. A lot of you have probably heard of Wolff's law. We're going to talk about that in just a second. But Davis's law is Wolff's law for connective tissue. I don't want to say soft tissue because soft tissue has become unimportant, but it is important. And how soft tissue deteriorates over time through the trauma, the inflammation phase, the muscle spasm, the adhesions, which adhesions is scar tissue, altered neuromuscular control, and muscle imbalance is the vicious cycle that patients go through when their ligaments are compromised, when the connective tissue is compromised. Wolff's law, which originally I thought was a biomechanical result, a biomechanical degeneration, but it actually is biochemical. When tissue's damaged, they lose the positive-negative ion balance. Positive ions are flushed out of damaged ligaments and muscles. Negatives remain, and then the negatives attract the most easily accessible source of positive ions, which is calcium, which exists in the body as Ca++, so it's very positive, and that's how you start to get bone spurs. Bone spurs deteriorate, end-plate sclerosis, all as part of Wolff's law. Wolff's law was written in 1858, and it says that bone remodels according to the pressure applied to it. So go to Simverta.com. Check it out. It's a way to document your patient comorbidity and your patient's need for ongoing care. What you see in front of you here on your left is an angular motion report with C4-5 and C5-6 past the pathology threshold and past the impairment threshold at C5-C6. That helps me determine my treatment plan. Number one, not going to adjust those segments. They're already moving too much. Then for translation, on the right-hand side, that report is showing at the very, very top pathologic motion of C1 on C2. 3 millimeters is the threshold for pathology there. 5 millimeters is the threshold for severe instability. So clinically, I need to know that that C1 on C2 is unstable, and we make other treatment plans as a result. You see what I'm saying? No predetermined treatment plans. It's all based on the clinical findings of this patient. Also, we have runaway translation at C2, C3, C5, and C7. All of that clinically pays into my treatment planning. And also, if it's a medical legal world, those are significant ligamentous injuries that are demonstrable. So, what are some of the comorbidities you need to pay attention to? Let me get back. Okay. So, we need to talk, number one, diabetes. Diabetes pretty much throws all the age dating out the window. I've seen someone with diabetes have high signal edema in the annulus of a disc over a year after the injury. Normally it dissipates in 4 to 6 weeks, maybe 8 weeks, but in a diabetic it can last a long time, especially if that diabetes is uncontrolled. High blood pressure is a comorbidity. Smoking, modic bone marrow changes type 1, 2, and 3 all suffice to prolong a patient's expected recovery. Documented disc degeneration, and what you see just to the side of that is a disc height analysis report from Cymberta. Facet arthropathy, ankylosing spondylitis, prior spine surgery with or without hardware, and morbid obesity. These things need to be documented, and then you're explaining to the carrier and to the patient the need for your treatment plan. What you see in front of you here is a biomechanical analysis from Cymberta demonstrating both primary lesions and compensations. The black lines that you see emanating from center reflect spinous process rotation. There's a primary lesion cervical, there's one mid-thoracic, and 1, 2, 3, 4 in the lumbar spine. That's the pre. Now, this person had a 12-visit treatment plan over 30 days. At the end of 30 days, we redo the biomechanical analysis, and this is the post that we see. Significant reduction of the rotation pathology. Significant. Now, this person had such a great response. This is not common, but they had such a great response. The pain went down from a 9/10 to a 2/10. So they were basically discharged and told to return as needed. But see, there's no predetermination here. This is based on the actual clinical findings. Let me scoot ahead so I can finish this time and we don't have to have a part 3. Wolf, most of you have seen this poster before. You might even hang it in your office. This is Wolf's Law pictorial. It shows cervical, thoracic, and lumbar, and gradual change in the bone and the disc space from narrowing discs, end plate sclerosis, disc height degeneration. So we're right at 1:30. Let me just scoot ahead here and get to my contact information. So again, I want to thank ChiroSecure for allowing me to bring you this information, both part 1 and part 2. You can review part 1, and now you have part 2 to try to put all this together. If you need me, let me suggest a text message to my cell phone or an email to that email address you see. So I'm going to turn this back over, and I appreciate your time today.